السلام عليكم ورحمة الله.
عليكم السلام ورحمة الله.
Good morning and good we have now 2 hours to discuss our presentation. Did you present any cases?
Yes, we prepared 2 cases. Sorry.
Or any problem or not? Okay. So hoping inshallah we can, yes, okay, let us give maximum 1 hour for every case so we can inshallah end at 12, okay? Let us start by Al-Kitab. Okay, who will present the first case?
Me, Anis, and Faiz will role play the first case.
So who is the doctor, Anis?
Yeah, I will be the doc, and Faiz will be patient's mother.
Okay, because I will give marks only for the doctor. Thanks for all to share and make it more. And who will be the one for the second case? No, I mean for the second case, who will be the one? Group 2?
For the second case, I will be we will be role play for doctor, and Wani for the mothers of the patient.
I cannot see your camera. So you are, what's your name? You are not clear in front of me. You are? Your name is? Shabni. Can you hear me or there is some problem in the internet?
Yes, we can hear you, doctor.
Okay, so let us start by Anis first.
Okay. So I'll start. Sorry. So hello, ma'am. How may I help you today?
Hello, doctor. So here is I have a complaint, doctor, because my child I want to come because my child have a problem, doctor. I have problem.
I didn't hear you just now.
Hello, can you hear me now?
Yes.
Okay. Yeah, my child is very sick, doctor. He is very sick. He has fever, doctor. Fever and rash all over his body.
So, okay. So do you know the nature of the fever, or you can just feel that his body is hot?
Unfortunately, I don't have a temperature from, so I don't know exactly what is the recorded temperature. But his body is I can feel that his body is very feverish. It's very hot for the past 6 days.
Oh, I see. Okay. So did he meet or with any sick kids or meet anyone sick before?
For the past week, no, he doesn't any contact with anyone is sick. His brother is very healthy. His playmate at the Tadika is very healthy. There's no complaint of anything sick children they has contact with.
I see. I see. Okay. So did the fever happen straight for 6 days? Is there any healthy that he had, or is it happening straight for 6 days?
Yes, the fever is unresolved. It's continuous. They are constantly fever throughout the 6 days, doctor.
Okay. Okay. Does he feel lethargic, or did he lost his appetite? Or
Yes, doctor. Throughout his illness, he very irritable, doctor. Constantly crying, and also he doesn't want to eat anymore. I think he has lost of appetite, doctor.
I see. Okay. So did you go to clinic, or did you give him any treatment for the fever?
Yes, during his fourth day of fever, I bring him to a private clinic. There, the doctor just give antibiotic and antipyretic only. That's it, antibiotic, and no admission to any doctor. So I think that is a result. However, the fever still persists the next day, doctor.
Okay, I see. Okay. So can you describe the characteristic of the rash that you mentioned just now?
The rash. I think the rash. I start to notice the rash during the fourth day of the fever, where it's originally I think that it's originate from his tummy, and then it spread through his leg, and then through his arm, from the abdomen to the proximity, and then the rash is reddish, it's raised. However, it's not itchy, I think.
Oh, okay. So it doesn't have contain any fluid in the rash.
No. There's no fluid. It's just
Did you
dry.
know? Okay. Did you notice your child like scratching on the rash? Is it itchy?
No,
The
I
rash?
didn't
No.
notice any scratching, doctor.
Okay. So so did you notice any rash also in the nappy area?
In the nappy area, I can't remember, doctor. I'm sorry, doctor. I can't remember.
Okay, it's okay.
If I
It's
notice.
okay. Okay. So did you notice anything unusual around his neck? Is there any swelling or?
Yes, I just noticed. I think there's a swelling, I think, on his left neck, doctor. Is it normal, doctor?
Actually, usually that is we call a lymph node inflammation. If do you see it only on one side, or like both side of his neck?
I cannot notice if there's both, but I only notice on the left side only, doctor.
Oh, okay, I see. Okay, thank you. So did you try to touch the swelling?
Yes, I did try to touch it, but when I touch it, my child start to feel irritable, start to
Uh,
show irritability, doctor. Show
I see.
discomfort when I try to touch it.
Oh, okay, I understand. Um, and is there anything else that you notice? Any dryness around his mouth, or
Yes.
changes in his tongue?
I noticed that. Yes, I think yes. I think that there's a bit dryness around his mouth, and also became fissure, doctor.
So it's like very dry, right?
Yes.
Okay. So how about his tongue? Do you notice any changes? Is it become reddish or?
In his aspect to his tongue, I think there's no obvious changes, doctor. During at home, doctor.
Okay, I understand. So how about his eyes? Is there any irritability with his eyes?
Yes, I just noticed that there's some kind of fluid come out of his eye, doctor. Discharge from his eye.
So is it just clear or is it whitish?
It clear, doctor.
Clear, okay.
A clear fluid.
Okay, I see. How about his hands and legs? Is there a particular condition that you see or anything?
I think just now that I think that his legs start to be, what is it called, swelling, doctor? Swelling his leg.
Oh, I see. Swelling. Okay. Around his fingers, is there any like dryness or peeling of skin?
I noticed on his right thumb there's some sort of peeling. The skin start to slash off, doctor.
Okay.
Peeling.
Okay, I see. Okay. So just if you notice is there any like redness around his BCG injection site?
As far as I noticed, no, doctor.
No. Okay. So during his during at home, was your child become pale, or is there any bluish discoloration around his lips or on his face?
Oh, no,
you
doctor.
notice?
There's
No,
no
okay.
blue color around my dog. There's no blue
Okay, I see.
discoloration.
Okay. Okay, good. So how about did he have any cough or was he sneezing at home?
Yes, I think it's only he's only coughed only one time, doctor. 1 day only, where she
Okay.
cough and
So
also have runny nose.
And runniness. Okay. So is the cough dry or is there you can there's a phlegm? There's phlegm in the cough.
I can't remember, doctor, but I only
You can remember.
noticed that he started noticed to have coughing only.
Okay, I see. Okay, thank you. Um, do you notice that he shows any appearance of chest pain or tummy pain?
No, doctor.
No. Okay. Is there any episode of diarrhea or vomiting?
Yes. One day, there's one time, I think during his fifth day of fever, that he start to vomit after feeding, doctor. The vomit the content is milk, doctor. He drink milk, and then he vomit, and also I think he has also diarrhea, doctor.
Diarrhea. Do you remember his stool? What is it like? Is it very watery?
Yes, it's very watery, doctor.
Okay. Is that the only episode, or did he vomit or diarrhea other times also?
During that time only, doctor.
That time only. Okay. So how about his urinary frequency? Did he urinate less or more, or any changes in his urine color?
No, doctor. Everything,
No.
his urine is normal.
Okay, so okay. Did he have any like seizure, no, during the fever?
Pardon, doctor, I
Or
can't hear you.
did he have any seizure episode during the fever,
Oh, no.
or fainting spells?
No.
Okay. So when he is playing or walking, did you notice his limb or like in pain while walking?
No, doctor.
No. Okay. So I just want to know about his past medical history. Was Haras ever been diagnosed with any medical condition before?
And I think for this, I think this is the fourth admission, doctor, to hospital. Because the first
Oh, okay.
admission was when he was 3 months old, doctor. Because for 3 days, I think because how his bowel slide to each other. What is it called?
Oh, okay, I see. Intercession, okay.
Intercession. And
Yeah.
that's when he is 3 months old. And then for his
Okay.
second admission, when he is 5 months old, I think that he has blood diarrhea. I think what is it called? Dysentery, doctor.
Oh, okay. Yeah. Okay.
And the third admission when he was 8 months old is admitted due to pneumonia, bronchopneumonia, doctor.
Oh, I see. So so he was treated there, and then is he well after that? After all those
Yes.
treatment?
After admission, there's no symptom similar to
Recurrent.
his due to his
Okay.
admission. Now there's no recurrent episode.
Okay. Okay, I see. Okay. So does
1 minute.
Haras have any drug
Anis,
or
you have 1 minute more.
okay, doctor. Does Haras have any drug or food allergy?
No, doctor. There's no any allergy, doctor.
And did he complete his vaccination?
Yes, I
Okay.
follow the vaccination schedule by the Kementerian Kesihatan.
Okay, good. Okay, thank you. And how about his feeding? Is he breastfed? Was he breastfed?
He was breastfed until he was 3 months old. After that, it's fully formula milk, doctor.
Formula milk. I see. And then when did he start eating real food?
He would start to wean at the age of 6 months, doctor. I give
Okay.
him porridge.
Oh, okay, I see. So, is there any member in your family that has any medical illness?
No, doctor. All of family members, his brother, his father, me, it's all healthy.
Okay, I see. Thank you. I think that's all that I want to know for now. Thank you, ma'am.
Okay, doctor.
Okay, can you summarize in 2 or 3 sentences the problem of the child?
Yes. Wait. So this is the long one. So basically, Haras, 1 and 8 months old boy, was brought to his mother with a complaint of 6 days unresolved fever and generalized polymorphous rash of 2 days duration. So the associated symptoms include neck swellings, cervical neck swelling, chesty cough, runny nose, and then dry fissured lips, and then swelling of his leg, and also there is a conjunctivitis, non-purulent conjunctivitis. So, but the and then but the fever was not resolved even after given antipyretic and antibiotic. So Haras was referred from Clinic Kesihatan Rompin to Hospital Pekan with suspicion of Kawasaki disease, and there was no history of traveling, water activity, sea contact, or any fogging around his house.
Okay, thank you. That's fine. So now your conclusion is 1 year, 8 months with fever and rash and another criteria for Kawasaki disease.
Yeah.
Yes? Is it the one?
Yes. Yes.
So what is the criteria of Kawasaki? What is the criteria? How can you diagnose Kawasaki disease by clinical criteria?
They will need at least 5 days of unresolved fever, and then there are at least 4
Okay.
out of 5 criteria, which are changes in the oral changes in the oropharynx,
So what is
and then
this?
changes in the oropharynx, like dry
What
fidget
is this
lips
5 criteria?
or strawberry tongue, and then non-exudative conjunctivitis, and also changes in the extremity, like swelling or discoloration of the skin, and then cervical lymphadenopathy, and usually unilateral. And then the last one is
Rash.
polymorphous rash. Last one is polymorphous rash that this patient also present with.
So what is the most important investigation you need to consider?
Investigation.
I think that we're going to do a lot of investigation, but what is the specific investigation you mustn't miss?
Is it echocardiogram?
Very good. Okay.
Okay.
That is the most important. For each situation, we have some important point we mustn't be late for it. Okay. What we suspect phase to find in echo phase.
For this just looking for any coronary aneurysm.
Very good. So coronary aneurysm, if we didn't pick early and treat early, it is a bit dangerous. So we can understand now the issue of problem-based. It may be the patient has fever, but now I am able to put beside it another criteria like skin rash. Okay, if fever alone, that's why I need you to how to think. If fever alone can be here in our country can be
Dengue.
dengue, very good. It can be flu or upper respiratory tract infection. It can be tonsillitis. It can be a lot. Okay, even we are suspecting lab 2 are suspecting a lot of differential diagnosis of fever. But now we put beside the fever a rash. So we are going to decrease our differential diagnosis. The most common fever with rash can be
Kawasaki, scarlet fever.
Kawasaki is not the most common. Yes, we can go scarlet, we can put measles, you can go German. Okay, and if this rash is visible, we can be chicken pox. If this rash can be hand, foot, mouth disease. So also we still have a wide differential diagnosis. Yes. if you are trying to search for other criteria, so you can see Anis and his hair, a nice role player. They picked, there is some changes in the eye, there are some changes in the mouth, in the lymph nodes, with the rash, with edema in the periphery, with. So all this will guide us to restrict our diagnosis. That's to mean if I'm going to reach a final diagnosis, I must have like many filters. Broad one, less broader, until I can. Sometimes at the end, maybe have two differential diagnoses. I must, investigation can guide me for that, okay? That is the importance of practicing medicine. Your software must be full of knowledge. Your hand must be full of skills, and then you must be able to work all this together. Good history, you must listen to the mother, and the history must be guided for about what you do suspect, okay? Because you may miss some important point. For the heart, you must ask if the patient has respiratory distress, has any, like, his heart looks like running, tachypnea, like that. Many things we try to ask simply. And during clinical examination, we must examine the heart and see if there are any signs of heart failure, if there any gallop, if there any cardiomegaly, okay, if there any murmur. All this will guide us also for the diagnosis. But we come to a conclusion now, and we must know that we are going to do a lot of investigation, okay? Most of them rule out, and most of them to make sure that there is no affection of some organ of the body, and then look into the Kawasaki, okay? In year 3, we didn't need to know a lot about management, just you must know the general line. That Kawasaki is famous with, what is the best treatment which are writing for the patient is who knows the treatment of Kawasaki, Anis?
Yeah, intravenous immunoglobulin.
Yes, so we must remember two important thing, IVIG and aspirin. Okay, so it is very important. Just in your year 3, you must know that this type of disease need a specific treatment, which IVIG and aspirin. But before that, we must work about what to do. I'm examining the patients. I mustn't miss, because if my brain is not occupied by the idea that fever more than 5 days, which is very important, to be 6 days and remember, oh, this is a very important. So I need to look for the eye, I need to look for the lymph, for the type of rash, for sculptating the heart. This is my job. Okay, you can continue. Do you have, I didn't want to put all theoretical knowledge here, okay, or repeat ourselves, but I need to concentrate in giving you the skills. Yes, this physical examination, come back for physical examination. Yeah, let us is professional and differential. The differential, okay. So can you tell us the positive findings, please?
Basically the examination. By the way, the examination was done on the 11th day of illness. So for the systemic examination, for examination, the patient was alert and conscious, and then not tachypneic, not lethargic or in pain, and there was still red and fidget lips, bilateral hands and feet swelling, discommission of his right thumb and left cervical lymphadenopathy. But other than that, anything else looks fine, which is no clubbing, no cyanosis, and no jaundice, and also not he is not paler. And for vital sign, he is no longer febrile. His temperature was 37 degrees Celsius, pulse rate 116 per minute, which is normal. Respiratory rate 35 breath per minute, which is also normal. Blood pressure 104/60 millimeter mercury, also normal. And then his oxygen level is also normal. And his anthropometric measurement, only his weight is noted, which is 11.56 kilogram.
Okay.
So for
What's
systemic,
okay.
sorry, doctor.
Continue.
Okay.
Yes,
So for systemic
continue, please.
systemic examination, for cardiovascular examination, his apex beat was in fourth intercostal space at mid-clavicular line, and the first and second heart sound were heard with no murmur. So basically, there is no abnormality found. And for respiratory, chest moves symmetrically with respiration, lungs have normal vocal resonance, and also good and equal air entry with vesicular breath sound were heard. Also, no abnormality were found. For abdominal examination, the abdomen was not distended and moves with respiration. Abdomen was soft and tender. Liver, spleen, and gallbladder were not palpable. And also, there is no visible dilated veins or no visible pulsation can be seen. For nervous system, there is no muscle wasting noted, no involuntary movement, fasciculation or tremor noted, and his muscle tone was normal, and the power of with the power of at least 4. So all his systemic examination seems normal.
Okay. You must comment about the rash. Please.
Oh.
The rash in our differential diagnosis are divided other non-blanching.
Oh, okay. Okay. I
If it is non-blanching, we must be very cautious. What can be the cause, Naqib?
Chicken pox for blanched.
Naqib.
Yes, doctor.
We found the non-blanching rash.
So the question is the causes.
Yeah. So what is the name of non-blanching? What is the name of non-blanching rash? It is known as Nurbrand. Okay.
Okay. Okay.
So it is very important if you found is I press and it didn't disappear. Okay, when I press, okay, it didn't disappear, non-blanching, which is known as purpura. So can be anyone can answer.
Can it be sepsis, doctor?
One or two examples. Yes, can be sepsis, especially pneumococcal meningitis and like that. What else? What is ITB? immune thrombocytopenic purpura. Okay, you must put it in our differential diagnosis. Okay, so it is very important to define if the rash is berberic or non-berberic rash. Is it blanching or not blanching? Okay. Yes, continue your presentation. Can I see the next slides?
Should I continue, Doctor?
Yes, yes.
Okay, Assalamualaikum warahmatullahi wabarakatuh. My name is Afrina and I'll be presenting the provisional and differential diagnosis part. But my connection is actually unstable right now, so I'm sorry if it's lagging. Okay, so let's start with the provisional diagnosis first. So our provisional diagnosis for this case is Kawasaki disease. Now, these are the supporting factors why this is our provisional diagnosis. So the ones colored in yellow are a part of the diagnostic criteria of Kawasaki disease. So in this patient, he had unresolved fever for more than 5 days, precisely 6 days. He had fever for 6 days. And then we have the, in the diagnostic criteria, there should at least have 4 out of 5 listed. So in this patient, he actually had all 5 listed. So he had polymorphous rash, he had fissure lips, which is basically changes, mucosal changes in the oropharynx. And then he had non-purulent conjunctivitis. He also had desquamation of right thumb, as well as bilateral swelling of hands and feet. So these are considered as changes of extremities. And then he also have unilateral cervical lymphadenopathy. Okay, and then the ones in blue are not a part of the diagnostic criteria. However, they are helpful signs, other helpful signs to diagnose Kawasaki disease. So he had irritability as well as diarrhea and vomiting. So as for the opposing factor, one of them is at the BCG injection site. In this patient, there's no erythema or induration. However, this is not a very strong opposing factor because not everyone with Kawasaki disease should have erythema or induration at BCG site, but this is actually one of the other helpful signs to diagnose Kawasaki disease. So that is the provisional diagnosis. Okay, so let's go to differential diagnosis. So the first one is measles. The points suggesting measles are fever, maculopapular rash, conjunctivitis, coryzal symptoms such as runny nose, this patient had, cough, and lymphadenopathy. But opposing factors for measles are the distribution of the rash itself, because in this patient, the rash started on the abdominal area, whereas the typical rash distribution for measles, it's usually starting at the face, and then it goes down to the trunk. And then there's also no coptic spots found in this patient, no coptic spots on buccal mucosa, which is suggestive of measles. And then for the immunization history for this patient, the vaccination for measles was already taken for this patient. So it makes it less likely for measles. And then another differential diagnosis is scarlet fever. So supportive factors for scarlet fever are fever, maculopapular rash, desquamation, and vomiting. So these are what the patient had. But against scarlet fever is that the rash in this patient was not characteristic of scarlet fever. So scarlet fever usually is characterized as diffusely erythematous, sandpaper skin rash, just like a bad sunburn kind of rash. Now, another differential diagnosis is toxic shock syndrome. Points suggesting toxic shock syndrome is fever, rash, vomiting, and diarrhea. But against this differential diagnosis is that this patient is not hypotensive. And then there's also no recent history to indicate that the patient had staph or strep infection, such as cuts, scrapes, or surgical wounds. This is actually a very important history. I recently came across a video where there's this 3-year-old child who just fell from his bike and had a minor scrape. And then the next day, he suddenly had a high-grade fever and then suddenly had a rash. And apparently he had a toxic shock syndrome that is so severe that his legs had to be amputated. So imagine having just a minor scrape, which could lead to toxic shock syndrome to the point that your legs had to be amputated. So this is considered as a very important history as well. And then another differential diagnosis is leptospirosis. Suggesting leptospirosis would be presence of fever, rash, vomiting, and diarrhea as well. But against leptospirosis is that there's no history of eating outside, so contamination of food. There's no history for that. And then there's no history of water activity. And also the rash for leptospirosis is usually described as transient petechial rash. So that is points against leptospirosis differential diagnosis. And that is all from my presentation. Okay.
Okay. Did you prepare any OSCE?
Yes, after the discussion.
Okay, go ahead.
So, what is Kawasaki disease? Actually, Kawasaki disease is lymph syndrome. It's an acute self-limited disease. Vasculitis of unknown etiology. It's a very febrile condition, and it is mainly affect children of 6 months to 5 years of age. Even though there is some rare case reported. It is more prevalent among male than female. Its ratio 5:1. Even though the etiology remains unknown, there is a variety of infectious agents that have implicated in triggering Kawasaki disease.
The voice is not clear.
And this Kawasaki disease is associated with infiltration of vessel walls by mononuclear cells, such as cell, related by IgA secreted plasma cell that can lead to destruction of tunica media and aneurysm formation, like coronary artery aneurysm. So the cases of Kawasaki disease merit referral to specialists, and the diagnostic criteria of a complete Kawasaki disease or classical Kawasaki disease must consist of fever lasting at least 5 days and at least 4 out of 5 of the following characteristic. Number 1 is bilateral non-purulent conjunctivitis that may begin shortly after the onset of the fever. Number 2 is changes of the oropharynx, such as injected pharynx, red lips, dry facial lips, and strawberry tongue. Number 3 is changes in extremities, edema or erythema of the hands or feet, and discommission that beginning primary. Number 4 is rash, usually concern. It is polymorphous but non-vascular in nature. Number 5 is cervical lymphadenopathy. It is larger than 1.5 centimeter diameter and usually unilateral but not common. The criteria is illness that not explained by other disease process. This is just example of the sign of the Kawasaki disease, non-prolonged conjunctivitis, red cracked lips, and this is strawberry tongue, like the redness of the tongue and peeling of the skin, commission. This is polymorphous and this vital lymphadenopathy that is larger than 1.5 centimeter. The sign that helpful in making the diagnosis of Kawasaki disease is irritability of meningitis or induration at the BCG site that we asked the patient before in the exploration, transient arthritis, area vomiting, our patient experienced vomiting sterile pyorrhea. Clinical phase of the Kawasaki disease. Number one is acute febrile phase. Lasts between 7 to 14 days. Ends with resolution of fever. Infection of the lips, swelling and erythema of the hands and feet. Rash and cervical lymphadenopathy. Number two is acute phase. From end of the day 25. The sign during this phase is discommission of fingers and toes, arthritis or arthritis and thrombocytosis. Number three is convalescent phase that begin with signs appear and continue until the rate becomes normal. Usually it's 6 to 8 weeks after illness. Yes. Disease, it should be considered as diagnosis in an infant with prolonged unexplained fever, but have less than 4 of the principal clinical features. And the compatible or echocardiographic findings that we find and higher risk of coronary artery dilatation or aneurysm. And echocardiography is very important as soon as the with two other criteria. The problem in Kawasaki disease that there is no it is lack of specific diagnostic tests and to support the diagnosis of Kawasaki disease, patient rash, fever symptoms like our patient, the physician information. For example, we can do count and we can expect anemia, leukocytosis, and thrombocytosis. In the acute phase, it is characterized by marked inflammation and immunodeficiency that we can expect to get leukocytosis for about 20,000 to 30,000 and we can expect to result of thrombocytosis, anemia, anti-cell and monocyte macrophage activation and there is slightly elevated element transaminase and serotonin less than 3 grams dialysis, and doses steroid pyuria, and there is more than 10 white blood cell per high power diagnose the patient because we want to management of the chronic disease. Number one is very important. Give the second dose is very despite other source of the fever. Oral aspirin to we have two doses anti-inflammatories. Until the patient no dose until ESR and the echo normalized. And echo cardiograph reveal sense of normalized and echo cardiograph reveals for the long term is giant coronary artery aneurysm, and we must do follow up after this medication. Give corticosteroid, enzyme, or cyclosporine. Inflammation and fever still persist. One the most important thing about chronic disease, that this disease can cardiovascular complication that is serious. Complication during the acute phase, you can have the myocarditis, pericarditis, valvular heart disease, and coronary arteritis. And this complication, coronary vasculitis, that 100% and this is really symptomatic and it may manifest as myocardial ischemia, infarction, pericarditis, also can occur in dilatation of the that 90% can lead to stenosis and lead to pulmonary ischemia. Myocardial infarction. The higher risk for coronary complication, the criteria is males. The patient older than 6 years or younger than 1 year of age. The patient that are unresponsive to IVIG or receive smaller dose of IVIG or did not receive within the 10 days of the symptom onset. So that's why it's very important for us to give the IVIG during the 10 days of the symptom. That's prognosis. We can see the complete recovery in children without coronary artery involvement mostly. Usually for the aneurysm with diameter of the 3 to 5 millimeter, 80% of the patient resolve. For the 5 to 8 millimeter, and at 8 millimeter, 8 the worst prognosis. It has shown the mortality 1 to 2% mortality, usually for cardiac complication within 1 to 2 months of onset in the acute phase. And this tend to more often show cardiac complication such as show more cardiac complication than very with disease.
Okay. How many slides do you have for OSCE? Just run it, please.
Bismillah. So I just made a very simple question. My name is Aiza. So I think we can just go through the OSCE first.
Maximum 5 minutes, please.
Yeah, it's just very simple. So these are the questions. So Doctor, should I call someone or just answer?
Okay, you have 5 minutes. You can moderate it.
Okay. Then it's a very simple question. Maybe I would like to ask Shamina, maybe just to simply answer the question.
1A, what are the abnormalities? I can see strawberry tongue and conjunctivitis with limbus sparing.
Okay. Then may you name the disease? Maybe just one etiology.
Might be Kawasaki disease, and the etiology actually is unknown, but it may caused by infectious agents, maybe.
Okay, so just like the main principle, how to treat this patient.
IVIG and aspirin.
Okay, correct. So these are the answers, detailed answers. Okay, next, second question. So a child came to the clinic with history of fever for more than 5 days. He was extremely irritable, and on examination, his temperature was 39 degrees Celsius. So may I ask, Faiz, may you answer the principal features?
Principal features, fever at least 5 days with 4 out of 5 criteria, which is conjunctivitis, rash, edema, lymphadenopathy, and mucosal involvement.
Okay. So 3 other signs that are helpful to make diagnosis. May I ask Jiha, please?
The other helpful signs might be erythema or indulation at the BCG sites, also diarrhea, vomiting, abdominal pain, and also hepatosplenomegaly.
All right, true. Thank you. Then I just want one complication of the Kawasaki disease. Wani, can you answer?
It could be cardiac complications such as coronary artery aneurysm.
All right. That's all for the questions. Thank you, everyone, for answering. These are the detailed answers.
Terima kasih. Now we can know how we start by a problem and how can we come to an important conclusion, not only for diagnosis, but for any specific issue related to that case, and even for the follow-up of the case, and how to counsel the family about all details, okay? This is our job in the future. It is not just a simple job. I'm putting my stethoscope and write some medication. No, it is a global responsibility. Good case, I will offer an IS-8, but this one with thank to all the group who share with her. Okay, this is your mark. Let's go for the second case.
Can you guys hear me?
Yes, Nafi.
All right. So my name is Muhammad Nakib. So I will be role play as a doctor, and one Nur Shazwani as a mother for the patient.
Okay, so try to make it 15 minutes. Then your discussion with the patient will be 15 minutes.
All right. Okay, Bismillahirrahmanirrahim. So, Assalamualaikum, Madam. I am Nakib, a third-year medical student that will be in charge of assisting you today. So, is this your child?
Yes, this is my daughter Laila.
How old is she?
She is 11 years old.
Okay, so what brings you here?
So my daughter has been suffering from a really bad fever for the past 3 days, and I am very concerned about that.
Okay, so how did you find out about the fever?
I noticed that my daughter's hand becomes hot to touch. That's when I know that she's having fever.
Okay, so like, did she had any fever before these past 3 days?
Yes, she does have fever before. It was about like a week ago when her hands are warm to touch, but I do not record the temperature. I just gave her paracetamol and then the fever seems to go away temporarily.
All right. And have you brought your child to any clinic kesihatan before?
So once I noticed that she's having high grade fever, I have brought Laili to Klinik Kesihatan Kurnia, and the doctor does suspect my daughter to have leptospirosis as she has been bitten by a rat before. And after that, my daughter then was referred to HTAA and was given only antibiotics as the blood results comes out normal.
Okay. And then like, I would like to know, when she's having the fever, did she like shiver and curl herself up?
As far as I know, no.
Okay. So other than fever, does she vomit in these past 3 days?
Yes, she does vomit.
Okay. How frequent does she vomit?
Around 10 times that day.
Okay. If you don't mind, can you describe the characteristic of the vomit? I mean, like, how much does she vomits, and you can just like compare to how many cups would it fill?
So each time she would vomit around a volume of one small cup.
All right. And like, what is the content of the vomit, and what is the color of the vomit? Is there any?
So as far as I noticed, the content of the vomitus was mostly just food content, and it is sometimes watery and yellowish in color.
So, does she have any breathing problems or bad cough?
None that I was aware of.
Okay, so she just vomit 10 times per day, no blood, yellowish in color, and the amount just around one small cup. Okay, got it. So, did she have any known allergies to it, any medication or food?
Yes, she does have allergy towards amoxicillin, which can cause her to develop rash on her body.
Okay. And well, before or after she vomits, like, did she have any stomach ache?
No.
Okay. And like, other than that, like, does she have other symptoms like diarrhea?
Yes, she does have diarrhea.
Okay, so how frequent did she go to toilet?
She around 5 times per day.
Okay. And did you have any idea regarding the characteristic of the stool? Like, what is the color? And I want to know the consistency of the stool. Like, is it a loose stool or is it a hard stool?
As far as I remember, it was chocolate in color and it is watery in nature.
Okay. And I would like to ask, like, did she eat only home cooked food, or did she had any outside food before?
Uh,
And does any of your family members have diarrhea?
we did not have any outside food, and no, none of my family members having diarrhea except for Laili.
Okay. And in these past 3 days, did you notice any changes in your child behavior? Like, does she become always tired and not active like usual?
I noticed that she becomes really tired and was less active than usual.
Okay. And I would like to know about her food and drinks intake. Is she a picky eater? Does she eat and drinks normally?
I don't think she's a picky eater, and she will normally have meals like 3 times a day in the normal.
So since she vomit, the appetite reduces, is it?
Yes, I noticed that Lily has lost her appetite recently. I think that maybe because she feels that she might vomit after.
Okay. Did you notice any weight loss?
No, I'm not sure about that.
Okay. And like, how was her appearance? Anything off?
I noticed that she's having some facial puffiness. That's all.
Oh, okay. So does the face, the swollen face subside in the morning?
I'm not sure about that.
Okay. And like, does she urinate normally?
Yes.
Uh, did you notice any changes of the urine colors, like any blood? And I would like to know that if she ever complained about pain to urinate.
As far as I know, no. Everything is normal for
Okay.
the urination.
And did your child complain for any night sweats?
No.
And did you notice any discoloration on her skin, like any rashes or any red spot?
No, I didn't notice any rash.
Okay. So other than all of that, did she complain other things like headache or dizzy?
As for headache, I don't think she have it.
Mm-hmm. And did you notice any nosebleed or bleeding gums?
Oh yes, I do notice some nosebleed and gum bleeding last night, and I have not noticed this happening before.
Okay. And how about body ache? Does she complain any pain at any of her body part?
Yes, Lily does complain of head and leg pain on both sides, which involve the whole lower limb.
Okay. Like since it's involved the lower extremity, so can she walk normally?
I think due to the pain, she has some limitations during
Oh,
walking.
okay. And can you describe the pain, like on a scale from 1 to 10, how would you rate the pain?
Lily says it will be 4 out of 10. The pain.
Okay. And did she had any accident or injury in sports that might be the cause for the pain at the lower limbs?
No.
Okay, so no trauma. And does she have stiffness on her joints in the morning?
She does not complain of any stiffness in the morning.
Okay. And I would like to know about, like, did you notice any bulging at the neck or the groin area or the armpit area?
No.
Okay. Okay, let's move on. Like I could see redness at her left eye. So is it developed in these past few days?
Oh yes, the redness in her left eye just developed in the past few days, and I thought it is normal.
And oh, okay. And does it have any type of secretions from the eye?
No, I'm not sure about it.
And does she complain that she feel pain on the eye or at the back of the eye?
Yes, she does experience pain at the back of the eye.
And how many siblings does she have?
She has 4 siblings, and she's the eldest one.
And do you and your or any of your family members have the same condition?
Both of her little siblings also having the same condition, except they do not have any redness of the eye.
Okay. So may I know where do you live?
I live in Sungai Isa.
And is your area common for dengue?
Yes, it is a dengue-prone area.
Okay. So does your home have any stagnant water like flower pot or used tires or anything that mosquitoes can easily breed?
I'm not sure about it.
Okay. So I want to ask about any rodent infestation at home?
Yes, there is rodent infestation around my neighborhood.
Okay. And have you traveled or did any outdoor activity, maybe like jungle trekking or swimming in the waterfall?
No.
Okay. And do you have basic amenities?
Yes, we do.
And what do you and your husband do for a living?
I am a receptionist and my husband is a factory worker.
Okay. Do you or your husband smoke?
No, we don't.
I would like to know that does your child follow the immunization program?
Yes, she completed her immunization.
Okay. Was she breastfed?
She was breastfed till 6 months old, and then she started weaning at 6 months old.
Okay. Can she do like daily activities on her own, or does she need your help?
Yes, she can. At home, she managed to do self-care activities like eating, bathing, and wearing clothes all on her own.
Mhm. And does she have any chronic disease, or and does she had any surgery before?
She does have tonsillectomy when she was 7 years old.
Mhm. Okay. And does she on any medication right now?
I know she is not on any medication.
Okay. And I would like to know about her birth history. Like, did you attend to all the screening session during pregnant? And do you have any health problem during your pregnancy?
Um, no, everything was normal, and I attended all antenatal screening.
Okay. Was your baby delivered at full term?
No, she was born preterm at 36 weeks. Okay.
Okay. And how was the baby's health after the delivery?
Um, does not have problem as far as I remember, and the baby was fine.
Mhm. Okay. And last, like, is there anything you would like to share?
I think that is all.
Okay. Okay, that's all. Thank you for your time. Later I would like to do a physical exam on Nur Laili to know more details about her conditions.
Okay, before Noor Laili, can you summarize for us, Nafi?
Yeah. Next slide, please. Okay. So the summary for history of presenting illness for this case. So this case is Nur Laili, an 11-year-old Malay girl with no non-medical illness, was presented to the Accident and Emergency Department of HTAA due to high-grade fever for 3 days duration, which is associated with persistent vomiting and passing out loose stool, as well as facial puffiness followed by developing spontaneous mucosal bleeding on the night before the admission. Uh, so the history. So for the past medical history, she had a tonsillectomy at age of 7, and there is no other non-medical illness. And for the drug history, she was not on any medication, and the mother is told that she is allergic to amoxicillin, which can cause rashes to her body. And for the immunization history, she completed her immunization course up to her age at Klinik Kesihatan Kurnia. And for birth history, during antenatal, the mother attended all the antenatal screening and all was normal. For perinatal, she was born preterm at 36 weeks of gestation via spontaneous vertex delivery. And for the postnatal, it was uneventful. Next.
So,
Uh,
okay.
uh,
Can you give me your top diagnosis?
so, my
Current.
for the provisional diagnosis, uh, likely is most likely having a dengue fever due to the symptom and also the she live in the endemic area for dengue.
So, what type of dengue fever? Dengue fever It's a
Uh,
very common.
I think like since I think she have dengue fever with apa dengue fever with warning sign to develop a severe dengue.
But you said she has mucosal bleeding.
Since she has the mucosal bleeding and persistent vomiting.
What is the
Yes, doctor.
warning signs?
The warning signs consists of intense abdominal pain, persistent vomiting, any clinical fluid accumulation like ascites or pleural effusion, the mucosal bleed, lethargic and restlessness, and liver hepatomegaly. And if we do lab tests, there will be an increase in the hematocrit and decrease in the platelet count.
Okay, there is an important clinical test of this child has mucosal bleeding to do. What is this test? Important bedside tests. Who can answer? It's a very important. You will do it bedside, even before waiting the lab results. Tourniquet test?
Full blood count?
No, I mean it is a bedside test, which is tourniquet test. What is tourniquet test? Are you able to open your pediatric protocol? It is very clear.
Buccal mucosal bleeding time.
Okay, we are waiting to you to answer. It is very important test. Can you continue your presentation? You must read about tourniquet test. Okay. At the end, we will conclude.
So let's move on to the physical exam. Okay. The child for physical examination, for general examination, the child was conscious and alert. She was pink and not septic look and not in a respiratory distress. And there was a cannula attached on the dorsum of her left hand without any active infusion. And for peripheral examination, there were no clubbing, peripheral cyanosis, or palmar erythema. And the periphery was warm, and the capillary refill time was less than 2 seconds, which is normal. And BCG scar was noted on her left shoulder, and there was no cervical lymphadenopathy noted. Thanks. So for head examination, the head size and shape were normal. There was redness of the conjunctiva and no pallor of the conjunctiva or scleral jaundice and no central cyanosis. And for the ear, nose, throat examination, there is no discharge from the ear and there is a presence of epistaxis, which the color of the blood was fresh red, sometimes comes with clotted blood. And the mucous membrane was moist without evidence of white coated tongue. Throat was not injected with no enlargement of the tonsils, and there is no oral ulcer was seen. Next. And the vital sign, the blood pressure was 112 per 68 millimeter mercury, which is normal. The heart rate is 106 beats per minute with a regular rhythm and a good volume. And the respiratory rate, 24 breath per minute, which is normal. And temperature is 37 degrees Celsius. No fever, and the oxygen level is 99% under the room air. And for the anthropometric measurement, she's weight 50.3 kg and the height was 146 centimeter. Next. And for abdominal examination, the abdomen was not distended and moved symmetrically with respiration. The umbilicus was central and inverted and no surgical scars noted. So basically there is no significant findings for abdominal examination in inspection. And for palpation, superficial, the abdomen was soft and non-tender. For deep palpation, there is no mass found and liver and spleen were not palpable and both kidney were not ballotable. Next. And when we do percussion, there was no shifting dullness. And when we auscultate, the bowel sound was heard. Next. So for respiratory examination, the chest move in inspection, the chest moves symmetrically with respiration. There is no chest wall deformity, no surgical scars or no or dilated vein seen. And for palpation, trachea was central. The chest expansion was equal bilateral, and tactile vocal parameters was normal bilaterally, and there was no dullness on percussion. And when we auscultate, there is equal air and entry on both sides of the lung. The vesicular breath sound was heard without rhonchi or crepitation. Next. For cardiovascular examination, inspection, there were no chest deformity, surgical scar, or visible pulsation. The palpation, when we do palpation, the apex beat was at the fifth left intercostal space at the mid-clavicular line. There was no trill or peristernal heave. And when we auscultate, the first and the second heart sound were heard and with no murmur. Next. In neurological exam, there was no abnormal gait or posture and no abnormal movement noted. And there is no muscle wasting. And for motor exam, the tone, power, and reflex were grossly intact. So let's move on to provisional and differential diagnosis.
Okay.
Okay. So the provisional diagnosis for this case would be dengue fever. So there are points that are suggestive of dengue fever, which is the high grade fever, and the patient's also having persistent vomiting and diarrhea, having spontaneous mucosal bleeding, and facial puffiness, lower limb pain, and the another important point suggestive of dengue fever is the patient lives in the dengue prone area, and also mentioned in the history the last foggy was done 2 weeks ago. And points that are against dengue fever in this patient is that the patient does not develop any rash. However, the rash only occur in 30 to 50% in patient with dengue fever. And also there's no abdominal pain. And there's also history of bitten by rat around 2 weeks ago. Next, the differential diagnosis of dengue fever. This is the list of example of differential diagnosis. Next. So first, chikungunya as one of the differential diagnosis. What are the points that suggest that supports chikungunya is fever, malaise, arthralgia, and also conjunctivitis. However, there are certain symptoms that seems not to appear in this patient, like the patient do not have any morning stiffness. The patient does not complain of any headache. There's also no rash, and the patient also do not have any history of traveling to endemic area with chikungunya. Next is acute gastroenteritis. The points that are suggestive for this differential diagnosis is fever, vomiting, diarrhea, and lethargy. However, there are few points that are against this as the provisional diagnosis, which are the patient does not develop any abdominal pain. There's no history of eating outside food that may lead to contamination. There's also no chills and sweating, and no headache found in this patient. Next is typhoid fever. Okay, so the points that are supporting the typhoid fever as the differential diagnosis is having the patient having a fever, vomiting, diarrhea, and malaise. However, there's also points that are against this to be the provisional diagnosis, like the patient does not live in or travel to any endemic areas of typhoid cases, and there's no abdominal pain associated with this patient, and no headache. As for malaria, the points that are suggestive of differential diagnosis is fever, vomiting, and diarrhea. However, the symptoms does not seem to occur in patients, such as like the points against this differential diagnosis is the fever experienced by the patient is persistent. There's also no profuse sweating found in this patient. There's also no chills and rigor, no abdominal pain, no headache, and during the physical examination, there's no hepatosplenomegaly noted. And last differential diagnosis would be leptospirosis. So the points suggestive for leptospirosis is fever, vomiting, and diarrhea, and also rodent infestation at the neighborhood of the patient, and also the patient comes with lower limb pain. However, the points that are against leptospirosis as the provisional diagnosis, like the patient does not experience any jaundice, there's no abdominal pain, also there is no hepatomegaly, and there's no history of recent water activity that may suggest contamination, and also there's no history of eating outside, same like contamination, and also the patient does not have any rash to suggest leptospirosis. I think that's all for today. This is just a comparison between dengue, chikungunya, and Zika fever for later reference.
Okay.
Okay, Bismillahirrahmanirrahim. So now we are going to discuss on dengue and what we can relate in our patient. Okay, give me a minute.
Okay. So for dengue is a common and serious mosquito-borne viral disease, and it causes by dengue virus, serotype 1, 2, 3, and 4. The infection is spread by Aedes mosquito, which are Aedes aegypti and Albopictus, and dengue, it usually affects all age groups. So the incidence of dengue, it is increased around the world, and in Malaysia it peaks in 2019. Okay, dengue, it spread usually in tropical and subtropical region. As you can see in the map, there is some red spot there, so it shows that tropical and subtropical region is there. And second is urbanization, and third is secondary infection. So regarding secondary infection, it may cause the patient to have a more severe presentation, where actually for the serotype, once the patient have already infected with one serotype before, it can induce a lifelong immunity towards the serotype. But once the patient have another infection, the secondary infection, she or he may only develop partial or transient protection against the other serotype. So that's why they may have a higher risk to develop severe dengue. And another thing is something called antibody dependent enhancement, where the antibodies that is present in the patient as they have already get infection before. So the antibody will bind to the current dengue virus, and the antibody cannot neutralize the virus because it comes from the other serotype. So it will develop a complex, and this complex will attach to monocyte. This can cause developing severe dengue. And other than that, like viral virulence and viral load. Okay. Now, moving on to the classification of dengue. For now, we use this classification, which are dengue without warning sign, dengue with warning sign, and severe dengue. Before this, WHO classified dengue into dengue fever, dengue hemorrhagic fever, or also known as dengue berdarah, and then dengue shock syndrome. But after the revise regarding the classification, and there is also some issues regarding that, so they comes with this new classification. Okay. So this is the new classification according to the severity. So as you can see in the box below, so how can we diagnose the patient dengue according to the clinical manifestation? First, they live or travel to dengue endemic area. Second, they have fever, a high grade fever. And third, they have two of the following criteria, which are nausea, vomiting, rash, aches, and pains. For example, myalgia, arthralgia, the periorbital pain. And then tourniquet test positive, I will explain it after this. Leukopenia and any of the warning signs. So the patient might have dengue without warning sign or have dengue with warning sign. So what are the warning sign? The box beside it. Warning sign are abdominal pain or tenderness, persistent vomiting, which are more than 3 episodes of vomiting in 24 hours, and then clinical fluid accumulation, which cause pleural effusion, ascites, and then mucosal bleed, for example, nose bleeding, gum bleeding, lethargy, restlessness, hepatomegaly more than 2 centimeter, and a lab test which it shows increase in hematocrit concurrent with rapid decrease in platelet count. On the other hand, for criteria of severe dengue, they may develop severe plasma leakage because of increase in the hematocrit, causing increase in the hematoconcentration. Thus, it causes the vascular permeability to be increased, and this leads to plasma leakage. So, severe plasma leakage may also lead to shock and fluid accumulation with respiratory distress. Second is severe bleeding. And third, it may also involve other organ like liver, central nervous system, and heart. Okay, let us see the clinical manifestation of dengue. So the incubation period for dengue, it where the infection occur until the establishment of the symptoms is range 3 to 14 days. And the illness will begin abruptly or sudden onset after 1 to 4 days after the incubation period. And the clinical phases of infection are three. One is febrile, followed by critical phase and recovery phase. For critical phase, it just develop in some patient who have increase in vascular permeability, which causes the plasma leakage and also severe bleeding. Okay, so this is the figure that shows the three cause of dengue illness: febrile, critical, and recovery phase. As you can see in the figure, that these three phases have different presentation or potential clinical issues. Like for febrile, it may cause the patient to be dehydrated. In critical, it cause shock, bleeding, and organ impairment. And in recovery phase, it causes reabsorption and fluid overload because of might be intravenous fluid therapy is being excessive towards the patient. Okay. Moving on to the febrile phase, the first phase, it occurs after incubation period and lasts 2 to 7 days. The sign and symptoms is abrupt or sudden onset of high-grade fever. High-grade fever is more than 38.5 degrees Celsius. Other than that, the patient may also present with facial flushing, as you can see in the picture, skin erythema, the redness of the skin, rubelliform exanthema, where it mimics the rubella rashes, which is the maculopapular rash. And maculopapular rash, it blanch once we press the skin, where the skin will become pale when we press. And then the patient may also have generalized body ache, myalgia, arthralgia, retroorbital pain, headache, photophobia, conjunctival injection, sore throat, and injected pharynx. Okay. Other than that, we might also notice that the patient have positive tourniquet test. Okay. So what is the tourniquet test? How can we do? So we need to inflate the blood pressure cuff on arm of the patient between systolic and diastolic pressure, and then wait it for 5 minutes. So after 5 minutes, we release the pressure and see if there is any petechial can be seen on the patient arm. So usually if we can see petechiae presented on patient arm about more than 10 or equals to 10, it indicates that the tourniquet test is positive. And then the patient might also comes with mild hemorrhage, for example, nose bleeding, gall bleeding, and then they also may have anorexia and nausea and vomiting. For full blood count, it shows leukopenia, where there will be reduced in white blood cell count. And then complication in this phase is dehydration and febrile seizure. In critical phase, so as I have mentioned earlier, that critical phase is developed in only some patient. Some of the patient is they will going through febrile phase and just jump into the recovery phase, but some of them might enter this critical phase. So the critical phase occur after 3 to 8 days of illness around the time of defervescence. What is defervescence? Defervescence is where the temperature drops to and remains below 38 degrees Celsius. And it caused by increase in vascular permeability and leads to plasma leakage. This critical phase lasts for 24 to 48 hours. And in critical phase, they also may also shows warning sign. For example, the clinical fluid accumulation, liver enlargement, severe abdominal pain, persistent vomiting, mucosal bleed, lethargy or restlessness, and increase in hematocrit, which indicates that the patient have hemoconcentration causing increase in the vascular permeability and leads to plasma leakage. This warning sign may also present at the end of the febrile phase and starting of the critical phase. Okay, so that's why our patient, she have the warning sign, but in febrile phase, because the hematocrit is normal, it is not increased. So the complication of this phase are severe plasma leakage, which causes dengue shock syndrome, respiratory distress, and then severe hemorrhage and severe organ involvement. Okay. So this is regarding the shock. So we need to classify according to compensated and decompensated shock, because it will help us to determine the management later. Okay. And the last phase is recovery phase, which occur 24 to 48 hours after critical phase and lasts for 48 to 72 hours. So what we can see in the patient, the general condition will improve. There will be gradual return of appetite, disappearance of GI symptoms, hemodynamic status will be stabilized, and increased diuresis, where the patient might get wet bed. And they might also develop a new rash, which is different from the febrile phase, where in febrile phase, they develop maculopapular rash. But in this phase, they develop isles of white in the sea of red, where there will be petechial rash. And once we press the skin, it will not blanch off, it will not become pale. It is different from the febrile phase rash, where the maculopapular rash will blanch upon pressure. Okay. Then the hematocrit will be decreased in this phase. However, they may also come with complication due to intravenous fluid therapy being excessive towards the patient. And they may also develop acute pulmonary edema because of that. Okay. Now, moving on to investigation. The best investigation that we can done is full blood count, where we need to monitor the white blood cell count, platelet, and hematocrit. So in our patient, the hemoglobin is normal in the febrile phase, but for white blood cell count, at the early febrile phase, it is normal, but it reduces after disease progress. Okay, that is for white blood cell. And for platelet, at the early febrile phase, it is normal but rapidly reduced and remain low till few days of effervescence. Okay. And hematocrit, it is normal. So it helps us to differentiate either our patient is having dengue fever or dengue hemorrhagic fever. Yeah, other than that, we can also do liver function test. Where it is also showed normal in our patient. Renal profile test also normal, so it indicates there is no kidney impairment, and coagulation profile. But the coagulation profile is not being done in our patient. Okay. Diagnosis that help us to confirm it, because the provisional diagnosis is from the clinical manifestation, but for confirming the diagnosis is by doing this lab investigation. So first, antibody detection, where we can detect IgG or IgM, and then virus isolation, detection of virus genetic materials, RT-PCR, and detection of dengue virus protein, NS1 antigen. So in our patient, she undergo rapid combo test where there is NS1 antigen, IgG, and IgM. So for our patient, it is positive NS1 antigen, but there is no IgG or IgM detected. But at the 5th days of illness, the doctor do the IgM test, and then it shows positive. So it indicates that the patient have primary infection compared to the secondary infection. And usually IgM can be detected in after 5 days of illness. For IgG, we can also use to know that the patient either have primary or secondary infection, but it can be detected after 7 days of the fever. Okay. And the last one is management. So how can we manage dengue patient? Symptomatic treatment, replacement of plasma leakage, treatment of shock, and management of bleeding. Okay, first, replacement of plasma leakage should be managed with intravascular volume repletion. So in mild cases, we might need to give the patient with oral dehydration salt, administer IV fluid for patient with intravascular volume loss, and blood transfuse for patient with significant bleeding or low hematocrit and fail to improve with fluid resuscitation. Next is treatment of shock, where we need to ensure the judicious or it being done in a good condition, fluid resuscitation, and detect hemorrhage if present, where we need to give fluid resuscitation, and once the hemodynamic stability is being restored, we need to gradually reduce the infusion rate to avoid the excessive giving IV fluid. Okay, then might be some other complication if it being excessive. And then close clinical observation after restoration of normal volemia. Okay. So this is the last slide, management of the bleeding. Significant internal bleeding should be suspected in patient with sign of intravascular hypovolemia without elevation of hematocrit. So we need to perform blood transfusion. Platelet transfusion is not effective in controlling hemorrhage, but may be needed in patient with severe thrombocytopenia, and might also need to administer intravenous vitamin K for patient with severe liver dysfunction or prolonged prothrombin time. Okay. Well, that's all for discussion.
Okay. The last which is the Oski. Just
Okay.
few minutes, please.
Okay, question 1. A 2-year-old boy infant presented with fever 3 days. On examination, he was febrile and his face shrunk, and extremities were erythematous, which blanched upon pressure, as shown in the figure below. And then his platelet count dropped to 83,000 per milliliter on day of 5 illness. His dengue serology IgM was positive. So what is your diagnosis? Dengue fever. Second is, what are 2 other possible findings? Sore throat, mild hemorrhage such as PTK, and what is your diagnostics investigations and S1 antigens and also serology test for IgM. Next, question 2. 8-year-old boy was admitted to the hospital with a 4-day history of fever, headache and malaise, and a 2-day of epistaxis and hematemesis. He has been diagnosed with severe dengue. So the question is, what are the criteria of severe dengue? Any of these: severe plasma leakage, severe bleeding, and severe organ impairment. And list the serotypes of dengue virus. We have 4 serotypes, which are dengue DENV1, 2, 3, and 4. And for the last questions, this boy was presented with fever, headache, and rashes. According to this picture, describe the rashes, islet of white in the sea of red, as shown at the recovery phase. What is the diagnosis and which phase of the disease? Dengue fever in the recovery phase. 3, give 2 complications according to your diagnosis, shock and multi-organ failure. And that's all for me for the OSCE.
Okay, thank you. I am just giving an example of, if you have patient with fever, it looks you are going to the terminal bus station to get bus. She can be hundreds of bus, and you must be able to define what you are going to choose. Okay. The first example was a rare disease, but very, very important. If we miss it, because even in developed countries, sometimes they are giving the IVIG in the emergency department. They are not waiting to go up. Okay, they are giving it very rapidly if it is clear. They know the early intervention, the early protection of the heart. The second example, after Kawasaki disease is the dengue. Dengue fever is one of the most common communicable disease. We must know it from A to Z, no excuse. Do you know if one patient of dengue die because of dengue, you must be investigated in your town and all over Malaysia, because if you are doing a good monitoring, that's why our number one of the treatment is close monitoring, and we must differentiate the level of care which needed. If simple dengue or dengue with warning sign or dengue with critical, either hemorrhagic or shock, this is a 3 different level of care and follow-up. Okay, that's why close monitoring and judicious use of the IV fluid. How much I need to give the patient, don't dehydrate and don't overhydrate. All of these are harmful also. Okay, that is my point, which I need you to understand, that you must know all the details. You must be able to give the full diagnosis. Okay, Naqib, you must say this is a dengue fever at which phase, and it is dengue with warning or hemorrhagic. You must be able to define, because this is different pathways. Okay, and because the recovery, the critical phase, every one of this has its own importance. We must be able also to know the investigation to confirm dengue. And despite it is a clinical, we still need to do the test. In the first 3 or 4 days like that, we can do NS1. On the 5th day and up, we need to do IgG, IgM. I know that there is combo and it is present somewhere, but ideally you must know, because many hospitals didn't accept to make both together. You must define why you are doing IgG, IgM in the first 2 or 3 days of the disease. It will come negative. But some area have, like KK now, have both together and it is available. So that is the issue. We must be able to define the problem with us. This child has fever, and then we are going to history. Our mind must be arranged. We'll do the history. I can pick from the history side where they are living, what is the exposure, is there any other member of the family, and then I will go like this situation. I got the history to know, is it just simple, is it warning sign, is it all starting to be hemorrhagic? It is very, very important, okay? So all this can come through the history, then I will go for clinical examination to confirm my issue. And at the end, investigation will help me to decide, because both of these cases are clinically diagnosed. The first one, Kawasaki, are very clear. The second one, with the history, with the skin rash, with, it looks also very clear, okay? But as your colleagues speak about differential diagnosis are very important. And don't forget that there is, in pediatric practice, we are dividing the babies just below 3 months. They are very important to take care. Some said 2 or 3 months. They are very critical because sepsis may not be defined to one area. It can be septicemia or bacteremia like that. From 3 to 3 years are also have its own characteristic, and you must be very cautious because they are very fragile and they can deteriorate very rapidly. And after that, it is nears adolescent, and like that, we are releasing the issue. Okay. You prepared today a good examples, okay, about fever and rash. I need one of you to add just with this slide, what fever without rash? The one who didn't share can do it, please. Fever, sorry, rash without fever. It is very important, okay? Just a simple one, okay? The other thing for dengue, it must be clear our pediatric protocol or our last clinical pathological guidelines are very, very important to go through it, please. Okay, now it's your turn if you need to ask any question. Okay, فهم? Two important learning-based presentation. Okay, thank you and see you inshallah again. Please correct your slides and your presentation and send it to me, please. Okay, don't forget.
Okay.
Thank you.
Thank you, Doctor.
Sorry,
Thank you, Doctor.
Naqib, you got 7.5, Naqib.
Yep.
If you are 7.5, your mark. Okay, 7.5. Thank you. Assalamu alaikum wa rahmatullah.
All right. Thank you, Doctor.